Okay, should I start?
All right, Thompson,
We're
go for it.
excited.
Okay. So the chief complaint is a 30-year-old female who presents with a week of progressive yellowish discoloration of her skin and sclera. I'm gonna stop here.
Steph, do you want to go first or do you want me to go first?
I can go first. I think very first thing, hearing yellow skin, yellow eyes that many of us worry about would be hyperbilirubinemia. I believe when your total bilirubin is in the mid-2s, you can start seeing some of these mucocutaneous changes. So this woman who potentially is turning yellow from that, we already kind of wonder, are we going to be framing this issue as jaundice? Thinking briefly through other things that can do this, not a huge list. If she's not ingesting a huge number of carrots or other things that have carotene in them, then I think jaundice is going to be really where we end up. And, as we hear the history, knowing already we're worried about jaundice, we can just start listening for other associated symptoms we'd expect. Is she itchy from that or other buildup, for example, of alkaline phosphatase? Does she have abdominal pain or not? Will we frame this as jaundice with belly pain or painless jaundice? Does she have nausea, vomiting, which can certainly go with kind of hepatobiliary causes? And I'm already kind of curious to think about in this young woman what risk factors she might have in terms of other comorbidities, family history, medications that she takes. So yellow eyes, yellow skin, immediately thinking jaundice, already knowing it's going to be from hyperbilirubinemia. I don't have a long list of other things really that are going to do that outside of some unusual ingestions. You want to give us some more?
Steph, can I ask you a question?
Yeah.
Or everybody? Does the fact that she's noted it in her skin as well potentially decrease or not affect the possibility of hemolysis? Like the cutoff for, I feel like you see it first in the eyes, right? Billy's 2.5, 3, whatever. But to see it in the skin, unless she's like very light skinned, and again, I don't know, but does that kind of suggest an even higher bilirubin, which usually doesn't happen with just hemolysis? So it was just kind of early question I had. Does anybody remember like at what point you start to kind of see skin discoloration as well? What level of bilirubinemia? Think of it more in like the maybe closer to 5 range. Yeah, whereas like I think of 4 as the upper limit of kind of jaundice or bilirubinemia from hemolysis in the absence of any liver dysfunction. But anyway, um, cool. Thank you. Thanks, Ravi, for yeah. All right, Sasan, go for it.
Okay, so for the past week, she has been noticing that her abdomen is getting bigger, so she's not noticing some abdominal distension. She's having diffuse abdominal pain, but mainly more on her right upper quadrant. She has nausea, poor oral intake, and constipation. In terms of itchiness, she denied any itchiness, any weight loss, or um, about like fevers and chills. She said she might have felt that she's having some fevers, but it's not documented. Um, and yeah, I'm gonna stop here.
Thanks, Sasan. Um, yeah, I think the constellation of symptoms with abdominal distension as well as pain and sort of GI symptoms is concerning for yeah, I mean definitely just further localizes, I think, obviously to the liver, and I think largely puts the possibility of hemolysis away. Um, but just makes you worry more about hepatic dysfunction potentially. But it really depends on whether the distension is gaseous or fluid, right? So if there's if there's development of ascites with jaundice, then that very much kind of localizes to hepatic dysfunction, which in this case, again, we'd have to kind of get to the endpoint underlying etiology, and the time course is a bit funny, right? But even chronic things like cirrhosis have to start being symptomatic at some point, right? And very often when patients kind of get to the tipping point of noticing their symptoms or them being severe enough to come to the doctor, things have been maybe going on for longer than the initially sort of presented time course. But whereas if there's a more of an acute or subacute cause of severe liver dysfunction, liver failure, that would potentially have a different set of underlying etiologies. But regardless, but the other possibility with the abdominal distension and pain and nausea is that the distension is just gaseous, and you're just dealing with maybe some trouble with biliary flow, digestion, and it could just be biliary obstruction, resulting in both the jaundice, extrahepatic biliary obstruction, resulting in the jaundice, and some of the other symptoms. And it's possible to have kind of stuttering choledocholithiasis that is both causing pain, anorexia, nausea, and then leading to jaundice without sort of rapidly evolving to cause cholangitis. And of course, the obstruction could also be unrelated to stone disease. It could be the mass lesion causing the obstruction. As far as intrahepatic cause of intrahepatic cholestasis, again, could fit with this time course. The pain would maybe be a little bit less common and prominent, but still possible. So I think just in terms of the logical kind of problem solving, I'm really curious whether the uh, distension is gaseous or liquid, and that could be, potentially answered on exam, maybe aided with point of care ultrasound, and then imaging the liver to see if there's biliary disease in the form of extrahepatic, intrahepatic dilation, as well as potentially discovery of the actual source of obstruction in the form of a stone or mass or something else. Steph, I think I didn't really address kind of immune or infectious causes of liver dysfunction and potentially jaundice and these abdominal symptoms in the form of autoimmune disease or hepatitis, like viral hepatitis, things like that. Do you think that kind of fits with the syndrome and the time course here too?
I think it could. It's been a week that she's had the distension, but I think you make a good point that, right, in chronic things can insidiously develop and then become more symptomatic to the patient over a shorter amount of time. So the actual time course of disease sometimes is longer than the time course of symptoms noted by the patient. And just to be explicit, I think if we're coding this as jaundice from a cholestatic injury with ascites, thinking about primary liver processes, including the infectious and inflammatory ones you mentioned, is important. With the presence of jaundice and ascites, the one additional anatomic place to think of besides the liver would be the post-hepatic region also, in terms of venous or IVC obstruction with Budd-Chiari syndrome. Just came to my mind because of this young woman, knowing if she's got any thrombosis risk factors like OCP use, etc. But to be clear, prehepatic sources of portal hypertension and ascites, like a big portal vein thrombosis, should be off the table because those shouldn't have the cholestatic kind of injury that's there. So I think I'm sort of thinking through, like, if this is ascites comes from pre, intra, or post causes of portal hypertension. The prehepatic isn't there because we think she's got some liver injury. And so I think most likely it's going to be a primary hepatic process as the source of injury. But when we get that ultrasound, I think doing Doppler with it early will be important just to take those post-hepatic vascular obstruction causes off the table also.
I think you're making me also just consider like or I guess reconsider just like hepatocellular dysfunction, not in the form of, um, cirrhosis, not in the form of necessarily like fulminant acute liver failure, but just transient hepatocellular dysfunction that can just occur with liver injury of whatever etiology. And I think you and I, practicing in the US have sort of a bias against acute viral hepatitis, whereas in most of the world where it's more common, this would be very much fitting with just acute viral hepatitis. In fact, like which commonly comes with like pain, hepatomegaly, abdominal distension, right? All of that fits, as well as hepatocellular injury and dysfunction. In fact, like the colloquial Armenian word for like for viral hepatitis essentially is yellowing. Like it's very common with Hep A and you know my mom and like a lot of people in the generations above me growing up in Armenia like at some point had like Hep A, right? So and they all like had transient subacute development of jaundice, some of these symptoms that in most cases, of course, is self-resolving. So I think that's Saucin, remind me where you saw this patient.
In Missouri here.
Okay. Still, I mean, viral hepatitis happens everywhere, so still possible. But tell us more, Sasan, unless you want to prompt any other discussion at this point that we missed.
Oh, great thoughts so far. I really like how much you were able to teach and tell us about like the presentation of this patient. So for her past medical history, she doesn't have any known diagnosis other than like anxiety. She's not taking any medications right now. No new like herbal supplements or over the counters other than Tylenol as needed for headaches. Family history, she mentioned that her mother was told that she has fatty liver. In terms of health-related behaviors, she has severe alcohol use disorder. So this could be part of like past medical as well. And her last drink was 1 day before presentation. And yeah, about like her past medical history, which I forgot to mention, she was seen in the primary care office in March, and she was told that her liver enzymes and liver function is not good. But she doesn't know any more informations about that. In terms of her vitals, temperature was 37.8, heart rate was 112. Blood pressure was more on the softer ends. It was 112/63. Respiratory rate was 22. She was satting normal on room air. BMI was 20. Generally, she looked ill appearing. She had she was like fully jaundiced. Like she had this scleral icterus and like mucocutaneous jaundice. Um, Her abdomen was distended, tense, with mild tenderness as well. And she had bilateral pitting edema, I would say around +2, but she didn't have any like astraxis during the admission. Otherwise, yeah, I'm gonna stop here.
Thanks, Austin. I think all of our thinking has pivoted, quite a bit, knowing about the significant alcohol history and the history of abnormal liver biochemical tests a few months before, really making us worry about potential acute on chronic alcohol-related liver disease. Zaven, help me fill this in, but sort of my framework for thinking about alcohol-related liver disease is it really can be on a spectrum in its chronicity and its stage of injury and potential for reversibility in the liver. In its most mild form, you can get some steatosis of the liver from alcohol without necessarily any liver biochemical pattern at all. When you check someone's labs, you can get After steatosis, sort of steatohepatitis, where there is an inflammatory picture and there's actually some injury, and this is where you might get some leak of AST, ALT into the bloodstream. Then, of course, you can advance to fibrosis and cirrhosis. So, sort of where on the spectrum this woman is going to be an important question. Knowing that her liver biochemical tests weren't normal in March doesn't necessarily mean she has chronic sort of cirrhosis from this. If she had just had a sort of binge, for example, and had a high amount of alcohol, right, there can be transient elevations related to sort of the acute toxic injury that then make it go away. But it makes you, again, wonder if her use has been heavy and prolonged. Has there been some chronic liver disease that is now worsened over the edge? She's developed portal hypertension, most likely at this point, with this distended abdomen. Again, we can percuss, we can get an ultrasound, but probably being ascites, and then with the lower extremity edema also speaking to kind of portal hypertension development. Again, to emphasize, portal hypertension can happen, right, with the chronic fibrosis and cirrhosis with advanced liver disease, but even acute alcoholic hepatitis in someone who didn't have a chronic syndrome of alcohol-related liver injury can acutely get portal hypertension and acutely get ascites there. So I guess what I'm saying is sort of the chronicity. There's certainly something sort of subacute to acute happening now. What's been happening in the background is important because I think we're seeing a pattern where the alcohol is the risk factor. But whether this is decompensation of cirrhosis versus sort of acute on chronic liver injury versus a new alcoholic hepatitis, maybe I'll ping Zaven to sort of help to see if we have enough information here to decide that. I'll just make two other comments before tossing it to you, Zaven. The drink one day before coming in, right, suggests the alcohol use had been ongoing, puts her at risk for the acute inflammatory injury of alcoholic hepatitis. I saw someone in the chat was already thinking about if it is, how severe is it? We can calculate a discriminant function score. But an important teaching point I've learned with alcoholic hepatitis is you can get alcoholic hepatitis with having ceased alcohol up to a couple months before. And a very, at least common story that I've encountered with patients is that before they came in, they were starting to feel crummy and bad, and they actually stopped drinking for that reason, and yet the inflammation of the liver injury progressed beyond that. So the one drink before, I think, enriches for alcoholic hepatitis, but I want to make the point if her last drink had been 1 month before, alcoholic hepatitis absolutely could be on the table, and we would want to ask her, hey, what made you kind of cut back on your drinking a month before, and wonder if the answer would be, oh, I was starting to feel a little bit bad and off. The only other comment I want to make is just the tachycardia that's there has immediately kind of primed me to worry a little bit about potential driving etiologies. Again, if she has chronic liver disease, are we worried about, bleeding and, or is there volume loss from her vomiting? But just want to make the point that hepatitis from alcohol is an itis, so it's inflammatory. So getting low-grade fevers, getting a high neutrophilic leukocytosis, getting tachycardia just from the hepatitis alone without an infectious or other source is absolutely possible and part of the illness script. Thank you for highlighting that temperature, which is almost 38 degrees. So very critical to rule out other sources of fever and tachycardia, importantly infection, because as we decide how to treat her, that'll play into things. But just to make the point that the itis part of alcoholic hepatitis can be very, very inflammatory. Not surprising to see white counts in the 30,000s, from just the alcoholic hepatitis alone. Zaven, do you mind commenting on just like, can we tell chronicity at all of kind of ongoing liver injury, and if there's anything else you'd like to add?
Not much. But yeah, I think this is a perfect fit with alcoholic hepatitis, which in contrast to like metabolic dysfunction associated steatohepatitis, which is more kind of smoldering chronic over years in its potential to cause hepatic dysfunction and cirrhosis. Alcoholic hepatitis can be an acute disease, sort of, and I don't understand. I don't know if it's well known, like why it happens in some people who drink heavily and not others, but once that kind of more acute, severe inflammatory process is triggered in the liver, it very quickly causes severe, and quickly I mean relative to like other things, on a time scale of days to weeks, maybe a couple of months, causes progressive liver dysfunction and failure, and can sometimes regress. Um, but the mortality is north of 50% once somebody presents like this woman has with alcoholic hepatitis. Um, so I think it's a good fit. And then the other thing that you sort of highlighted that I always struggle with too, it very much is an itis, right? It swells, it hurts both locally and systemically. Um, but then the source of mortality in patients with alcoholic hepatitis is also a most like highly attributable to infection. So I think the balance of realizing you could have sterile inflammation, but also being very vigilant and quick to treat complicating infections is difficult to achieve without, over treating for infection. So I think definitely um, not holding back on ruling out all possible sources of infection is really important in these patients. And I also wouldn't, necessarily, even if the rest of the picture is perfect, right? The AST is not over 500 and, about twice, 2.5 times the ALT. Like even if the biochemical profile also fits with alcoholic hepatitis, I think it's still important to not miss other potentially more treatable sources. And meaning ruling out chronic viral hepatitis, which is often comorbid, kind of getting a little bit more granular with how much acetaminophen she's been using um, for these headaches and whether there might be a contribution there. Um, and we can talk more about the treatment later, potentially, but some nuances there too to consider.
Is it okay if I ask a question? Like, what would you do for this patient? We're gonna admit them. Like, what are some empiric orders that you would put for her, or any like site kind of protocols? What do you want your interns or like residents to do for that patient initially before you get to see them, just to get like the full picture, or what can help you?
Take it away, Zaven. Thanks for priming us, Susan.
Great question. Yeah, I mean, I think I wouldn't delay seeing them, right? I think just obviously getting your own story, your own exam. Obviously, some of the labs will be quickly available and might also inform decision. But I would actually go the opposite way and say, Sasan, that if the primary hypothesis is that this is alcoholic hepatitis, I would actually recommend not overreacting or acting too quickly. So, for example, even if prednisone one decides to give prednisone to treat alcoholic hepatitis, it is not an emergency. It is not time sensitive. Its benefit, if present at all, is very marginal. And the concern of further immunosuppressing and sort of increasing risk of infection even further is very real. And I think this was stretched. There was a great episode, I forget if it was on the Curbsiders or Core IM, where Elliot Tapper, one of my favorite sort of online hepatology educators, um, yeah, it was that. Thanks, Alec. Yeah, I guess it was Core IM, but one of his key, he was just urging like, don't hurry, like hurry up and wait, like slow down. It's not, don't give the prednisone like empirically or upfront or on day one. It's just better to actually take some time, make sure you have a clear diagnosis, and focus on just supportive care. Don't make this patient NPO, right? Like just provide nutrition. If there's a risk for alcohol withdrawal, kind of manage and support that. Look for infection. Look for other contributing or complicating factors. But I don't think, I think we need to get a clear picture of everything before certainly taking any therapeutic steps. Unless, of course, if we learn that this patient's very anemic and having melena and the INR is 3, like that's a different story, right? I think, but based on what we've heard so far, um, and I would focus mostly, I would encourage my interns or whomever to mostly try to understand the picture better, and provide supportive care until we have kind of a clear understanding of everything that might be going on.
Okay, thank you. So now moving to the CBC, her white blood cell count was 17.6 with neutrophil predominance. Hemoglobin was 9.6 with an MCV of 101. Platelets were 216. In terms of her potassium, it was low. It was 3.1. I don't have all the data, but I'm just gonna give like some of the pertinent things. Albumin was 2.3. INR was 1.8 and peaked to 2.1. Her initial bilirubin was 23.9. AST was 141. ALT was 48. I don't see the alkaline phosphatase, but I think it was like mildly elevated. In terms of right upper quadrant ultrasound, it ruled out cholelithiasis or biliary obstruction. And we had like patent vasculature as well. In terms of her CT abdomen and pelvis, it showed some cirrhotic morphology with evidence of portal hypertension. There was splenomegaly, ascites, and small collaterals were seen, and mild peripancreatic fluid and fat stranding, but her lipase was normal. Yeah, and I'm gonna stop here.
Thanks, Austin. I'll comment on the CBC and maybe some of the chemistry entities. Zaven, if you want to kind of tackle your thoughts on the imaging. We wondered about neutrophilic leukocytosis coming into the case, both with her risk for alcoholic hepatitis, the tachycardia, and there it is. I think the requirement to make sure there isn't concurrent infection remains with that. Although, again, that could be from alcoholic hepatitis alone, if that is what this is in the end. Interpreting the macrocytic anemia, first, of course, I don't know if we have a baseline, Saucin, but how different is that from usual will make us kind of worry about potential risk for GI bleeding. I think when in doubt and when it's not clear from the history, doing a digital rectal exam, we should just have a low threshold because that'll very quickly change our management. If we see melena or frank blood on the exam, we're going to really kind of move down our therapeutic pathway for GI bleeding. And then the macrocytosis is expected, both from what looks like potentially chronic liver disease as well as alcohol use itself alone. You can get a hemolytic anemia with alcohol use that's more rare, called Zeev syndrome. I think that's a less likely explanation, with excess reticulocytes being the cause of the high MCV. Could check at reticulocyte count if we wanted, but I think the macrocytosis is well explained by two potential comorbidities that we know about now. The hypokalemia, I think, speaks to the chronicity of her alcohol use. It's a very common lab finding with heavy alcohol use, both lack of intake, but really also potassium wasting that happens in the channels as well. And we talked about supportive care and nutrition being so important for her liver disease. Knowing that we're going to feed her, she's at very, very high risk of that dropping even lower. Anyone with chronic alcohol use is. So keeping an eye on the potassium, making sure we have a phosphate also, just knowing her history of alcohol-related kind of factors will make her at risk for bottoming those out. And then the liver injury pattern, I think it fits potentially from either, acute hepatitis from alcohol or chronic liver disease. We see predominant cholestatic injury with that bili very high, the 2-to-1 AST to ALT ratio. And then her INR elevation speaks to some synthetic dysfunction. Chronicity is hard to tell from the INR. We have our albumin of 2.3. The albumin of 2.3 speaks to a little more of a subacute course. The half-life of albumin is 20 days, so it takes some time to get your albumin lower when it's from liver synthetic dysfunction. The half-lives of the coagulation factors, in turn, are a lot shorter, and so you can very quickly elevate your INR with injury. But the lab pattern here does look like the synthetic dysfunction is at least kind of subacute. Zaven, feel free to build on that or give any info on the imaging studies.
Yeah, I think the imaging maybe helps a little bit more with time course. Not that it particularly matters, honestly, in terms of kind of management. If the liver morphology is more sort of cirrhotic, nodular, shrunken, that definitely doesn't happen, in a week or a month. But again, you can have this presentation with just alcoholic hepatitis as well without sort of preceding or more chronic development of cirrhosis. And you can, a lot of patients like this on imaging will actually just have like hepatomegaly and, some changes in density or echo texture, but not necessarily sort of a nodular or cirrhotic morphology. But yeah, the same with like the collaterals, kind of the evidence, the splenomegaly, the evidence of portal hypertension too. That takes a little time to form. But regardless, whether this was a process, years in the making or weeks or months in the making, the management is going to be, supportive care, treatment of complications like infection or bleeding, and then, very aggressive uh, help in alcohol cessation and nutritional support and things like that. And then the imaging did confirm the ascites, and we certainly, it sounds like for if the abdomen was tensed on exam and she's having pain, there may be sort of a therapeutic paracentesis to do, but there's certainly a diagnostic paracentesis to do to rule out complicating spontaneous bacterial peritonitis that could explain some of the systemic inflammation and certainly be a very meaningful point of intervention. I think I want to make clarify too, Steph, that she said that albumin takes longer to fall in the setting of if it's only driven by synthetic dysfunction because of its longer half-life. But in settings of acute infection or inflammation, the albumin, the half-life is shortened, so you can have hypoalbuminemia that develops over a week, for example. That doesn't necessarily reflect hepatic dysfunction or malnutrition. You can just have a low albumin from infection or pancreatitis or whatever that happens more quickly, which is sometimes I feel like it's more of a point of confusion from a lot of surgeons who cite hypoalbuminemia as sort of a risk factor for surgical risk factor for malnutrition or whatever through malnutrition, but in fact it's more of a case for potentially strengthening the indication for surgery in the form of like, hey, this infectious source or whatever, whether it's a necrotic toe or diverticulitis or whatever, is causing a lot of systemic inflammation and various effects.
Should I proceed?
Please.
Okay. So in terms, we got like a chronic hepatitis panel. We got virology was negative, autoimmune causes were negative, Wilson, hemochromatosis, they all came back negative. Initially, we weren't able to get a tap. Like IR said, there were no pockets to do like a paracentesis on her. We treated her like empirically for SBP. We did correct her electrolytes. We gave her thiamine, all like these supportive therapy as well. And she was like on the CWAP protocol. During her hospitalization, her labs kept on like fluctuating, but within like a similar range of her initial presentation. And then she would spike some fevers as well during her hospitalization. So as we weren't able to get a tap, we also broadened her antibiotics to include Zosyn, and we weren't really able to find a focus for her for like an infection. And then she did eventually get a paracentesis, and it didn't show any evidence of SBP. There were some PMNs, and her like cell count was around like 48, but we don't know if like she initially had SBP or not. She did get an EGD during her hospitalization, which showed two small varices that are barely noticeable, but there's no evidence of like bleeding as well. Is there anything else that you guys want um that I forgot to mention or you feel like you need?
Thank you for sharing the additional workup. It was people importantly were pointing out in the chat, we shouldn't have total closure in case we can find another etiology, fingers crossed, an etiology that could be treatable. But the workup that was completed for kind of chronic liver injury, thank you for sharing that. And unfortunately, it was negative, not giving an alternative etiology, suggesting that alcohol use is the main driver here. I will say, Sausan, that question, the challenge of getting an early paracentesis, having a high enough concern that you're treating clinically, and then that how do you interpret the ascites, days after the antibiotics? You don't know. I like it's certainly right. If I don't know how many days afterwards her cell count was 48 in there, but if it was 5 days before, it's hard to say. It could be plausible that it was over 250. So then you're just in a therapeutically difficult point because the two other decisions to make, if you have considered whether someone has SBP and you don't know before, are the benefit of giving concurrent albumin, sort of for the mitigating the risk of hepatorenal syndrome. I feel like that's forgotten sometimes, but if you're treating empirically for SBP, it's ceftriaxone and it's albumin to mitigate risk of HRS. And then the other question is, does she get secondary prophylaxis when she finishes her 5 days of ceftriaxone? So that's a very common dilemma because of sometimes the logistical challenges, the minimal amounts of ascites that are in there. But just to make the point, if you're empirically treating, the treatment includes albumin, and that sort of decision of what to do for secondary prophylaxis, sometimes you just don't have enough information to know for sure. And I don't know. I don't know kind of the right way to guide that decision. Other comments you want to make, Zaven?
No, the main one was what you said. I think that's such a great point, Steph, that we see that it's it's hard to tap, or maybe we don't have the right person to do it right now, so we'll just treat empirically. But it doesn't, when people do that, they're really just giving ceftriaxone. But albumin, in addition to antibiotics, has such a large effect size on mortality and true SBP that if there actually is underlying SBP, then you're way under treating and missing an therapeutic opportunity. Whereas if you give everybody albumin and ceftriaxone, and again, there's the harms of antibiotics are well known, but like I think giving albumin when it's not indicated isn't benign either, neither in terms of cost nor in terms of sort of unnecessary volume expansion, and can precipitate variceal bleeding if you sort of overshoot and things like that. So I think I think it's really critical to actually establish whether someone has SBP or not for all of those reasons. I think Sasha, you guys also did great to sort of empirically broaden the treatment, because even though the default antibiotic most people use in SBP is ceftriaxone, most of the time you don't end up with like a microbiologic diagnosis and susceptibilities, right? So you cover gram negatives, but these days, like in our hospital, like a third of E. coli are resistant to ceftriaxone. ESBLs are so common where if somebody has a history of ESBL producing colonization, then a penem potentially would be an appropriate first line treatment. And certainly if someone doesn't get better, there's an indication to broaden like you did, or there's an indication to repeat a tap and see if the neutrophil count is going down. So I think all of those are just kind of nuanced considerations of managing situations like this, and the reason why, like, if you can get a tap, it's so helpful. And there's like emerging data the last couple of years that actually the sooner, it is indicated to do a diagnostic paracentesis on all patients with cirrhosis and ascites in the hospital, no matter what they came in with for. And there's increasing data that the sooner that happens, the better the outcomes too. But that situation where you think there's going to be ascites because the patient has liver disease and the belly is super huge, but you look and you're like surprised that there's not a lot of ascites. That's very common. And the reason for that is that a lot of these livers are big and they themselves take up space in the abdomen. Their spleens are big and they take up space, right? But also their intestines are very swollen, like that portal hypertension, impaired venous drainage of the mesenteric circulation just causes, like, when you look with the ultrasound at these patients, like their guts are just like chunky, and their intestines are actually like big and take up a lot of space, and that's a big part of the abdominal distension. So it's I've just seen that so many times that it no longer surprises me where you could bet that there's going to be ascites just based on how big the belly is, and because and the rest of the patient is thin, but no, sometimes there's not any actual there's not a lot of fluid in there. So Austin, did you want us to comment on any other kind of questions or anything you wanted us to comment on specifically?
No, thank you so much for everything that you shared so far. But it was very like educational. Um, so in terms of like the diagnosis, we weren't honestly we weren't able to find any other cause of her like liver injury other than like alcoholic hepatitis. Um, and so her diagnosis was like newly diagnosed cirrhosis with like decompensated picture secondary to alcoholic hepatitis. Um, yeah, eventually her lab started to downtrend like after like around a week, but they kept on like initially fluctuating. She would spike some fevers without any localizing infection, as I mentioned before. And we eventually did, and hepatology was also on board with us. We didn't give her prednisolone just because we weren't really sure but like weighting the benefits and risk in case if there's like an infection that we don't know of. So we decided to like hold off on the prednisone for now. Eventually the patient was feeling much better and she was like advised to stop drinking alcohol. Um, and yeah, I wanted to share this case because one of the learning things is like the labs and being like fluctuant in the during the admission was something like new to me. And apparently it can be seen in like cases of alcoholic hepatitis that you initially see some fluctuations and then they would start downtrending. They wouldn't really downtrend fast just like once you stop alcohol. I don't know if that makes sense, but that was one of the learning things. And thank you both for discussing.
Thanks for a great case, Austin. Something that we think about a lot, just jaundice, liver injury, the risk of alcohol use, really, really pertinent case. There's two questions in the chat, Zaven, that we could quickly comment on. I can tackle the first one. Jennifer's asking back for that initial elevated INR. Would we give vitamin K to see if it's all nutritionally related? I think yes. Even in the absence of bleeding, just a few days of oral vitamin K to see if there's any improvement because of a vitamin K nutritional deficiency could be very helpful to sort of parse out the picture of how advanced her synthetic dysfunction is. So I think giving a trial of oral vitamin K makes a lot of sense. And then Zacharias is asking a question I've asked myself a lot. It's just sort of, how do you tell what is decompensated cirrhosis versus sort of acute on chronic alcohol-related liver disease? That's hard, right? And we have radiographic evidence here suggesting there's cirrhosis, but honestly, like what the underlying injury is requires a biopsy, and that's not done in all cases. It's done in some cases when the picture's unclear. So one of the hepatologists we work closely with at the VA here, his teaching on it is sort of to think of it really as just acute on chronic alcohol-related liver disease, and that it can sort of look like a decompensated cirrhosis, even if you did a biopsy and there was no actual kind of cirrhotic morphology there. So I think truthfully, sort of hard to tell if it's decompensated longstanding cirrhosis versus more of a sort of acute kind of injury. But Zaven, I don't know if you have another way to sort of define that. Clinically, the management is the same, but I have had that same question before when it's not clear how long underlying liver pathology has been there with the acute insult with alcoholic hepatitis on top.
Yeah, I don't have a better framework. I agree. I think the other comments in the chat were about use of pentoxifylline, which, yeah, I think that's thanks for bringing that up, Richard. And I agree with Ravi. From what I know, like the evidence really doesn't support its use. For corticosteroids as well, again, it's very mixed, and the benefit is marginal, if any. I think one thing that I people don't sort of use as much maybe as there's evidence for is if you are giving steroids. Here I can just quickly share the screen, but if you are using steroids, the addition of N-acetylcysteine in this 2012 RCT led to better outcomes in the setting of alcoholic hepatitis. Again, these were all patients who got glucocorticoids, and then it was either N-acetylcysteine or placebo. But people can kind of look at the study more closely if you like, or if you encounter a situation like this. Oh, hey, Alec, I guess you read my mind.
Spot on, yeah.
Yeah.
Her initial severity score was very high, right? I don't know if anyone calculated in their chat, but her Madry's discriminant function was certainly over 32 when she came in. But Sawson, that dilemma of these fevers, this white count, are these from an infection? We're not, is so common. Plus, I know someone quoted the Stopa trial in the chat, that really showing like no mortality signal at the 90-day mark. It's been very interesting in the last 10 years seeing the threshold for giving steroids getting higher and higher, I feel like. And there's a lot of patients where we find either relative or absolute contraindications for it. But they're in the right host, like that is a therapeutic option that's there. I'll just say in the last few cases that I've seen, there's just been enough uncertainty about contraindications and enough knowledge of that the steroids may not help in the end. The last couple cases I've at least been involved in, steroids have not been given, but that data is there. The only final comment I want to make is alcohol cessation is such a critical part of her treatment. Naltrexone is the best of the meds that we have, easiest to take, but there'd be a lot of discussion about whether that's appropriate for this woman. We've all learned with liver disease, naltrexone, which is hepatically metabolized, can't be used. There's actually data, and there's a Things We Do for No Reason article that came out recently in the Journal of Hospital Medicine showing in many patients, even with cirrhosis, naltrexone actually has a net benefit, that actually when you look at mortality, it's improved, and the actual rates of liver injury occurring from naltrexone are actually quite small. It's a data-free zone when it comes to advanced alcoholic hepatitis or advanced sort of class C cirrhosis. So in this woman, you would need to sort of have a discussion and decide. The alternative is a camprosate in terms of medication assistance for her alcohol addiction. So hard to take, though. It's 2 tablets 3 times a day. It's just such an inferior option when it comes to adherence, and just a little bit less effective than naltrexone overall. But I think the severity of at least her acute liver disease here would need a prompt kind of a thoughtful discussion about risk benefit of naltrexone. It still might be the option for her, but I think you'd see a lot of questions and hesitation about using that agent. But just so you guys know that there was this nice short review in JHM recently about the fact that using it in a lot of patients with liver disease is safe and quite effective.
Thanks, Steph. Hans, do you want to sum up some of the discussion with the teaching points?
Yes, it will be just a few pertinent points. We had a patient, 30 years old. She presented with progressive discolorization of the skin and sclera. She also noticed itchiness. And we were thinking about hyperbilirubinemia, and yellowish skin already shows when about the bilirubin is around 2. An itchy skin, abdominal pain, nausea, vomiting is what she also said. And then our question was, is it hemolysis or is it coming from the liver? Hemolysis, our bilirubin is usually less than 4. That is, our blood work should give us some clue between direct and indirect bilirubin. Patient also complained of right upper quadrant pain, nausea, vomiting with distension. Distension of the abdomen makes us think about gas. What causes the distension, liquid or solid? And the localization, we have right upper quadrant pain. there could be the liver, but I also would like to include the possibility of pancreatic problems or the stomach, which is roughly the same area, or the diaphragm. Now we have a very strong clue from our past medical history that it could be the liver. And there is the question, is it a metabolic substance? Is it an infection? Is it an autoimmune disease? Or is it a malignancy? Let's look out for a coagulable state, portal hypertension, do an ultrasound abdomen. Patient was later seen in the physical exam as having ascites with edema, and there we found risk factors in her past medical history. It was alcohol abuse, it was fatty liver, and a fatty liver and alcohol abuse, even months after cessation of alcohol, the patient might still develop ascites and liver problems. And our concern was now to rule out infections. Hepatitis, is there a possibility for a viral infection of the liver, or is there acetaminophen abuse or abuse of other substances which could affect the liver? And an important question that came up was, what would be our empiric treatment in alcoholic hepatitis? And here, probably the pearl that we have time, we should get a clear diagnosis first, and then the diagnostic paracentesis, patient had ascites, should be performed to rule out a spontaneous bacterial peritonitis. Then our treatment could include empiric antibiotics like ceftriaxone, meropenem maybe, albumin with caution because it could cause volume expansion. It could also decrease the MEL score, which then has an effect on our decision-taking for liver transplants. Then we also would like to give the patient, if tolerated, a high-calorie and protein diets, possibly corticosteroids. Here I have to make myself more knowledgeable in how far it reduces the mortality. And the corticosteroids with caution, we don't want to cause an infection. Then neutrophils are in general very much elevated during hepatitis from alcohol. And these neutrophils significantly contribute to the inflammatory state of the liver. The patient was eventually diagnosed with a decompensated liver cirrhosis secondary to alcohol abuse. Thank you very much for this beautiful case. I think it was very educative.
Thank you, Hans. That was awesome. Thanks, Hassan, for presenting the case. Ravi, thanks for pinch hitting last minute, and great to see and chat with everybody. Y'all have a great afternoon.
Nice to see everyone. Thanks for joining. Bye.